Hello and welcome to this LVS webinar. I want to thank you for stopping by and taking the time to listen to this talk. I'm Sivert. I am the internal medicine consultant at LVS, and today I'm going to give you a short talk about fever and unknown origin and also my approach to these patients. The overview of the talk is as follows. We're first going to go through a couple of definitions. So we're going to go through hypothermia, fever. Then we're going to go through the causes of fever in our dogs and cats, and then my approach to FUO, with us ending with a case at the end, highlighting some of the stuff that we talked about. So let's start with definition. So basically what we're talking about is an increased body temperature. That could either be caused by fever or it could be caused by hyperthermia. The definition of fever is an increase in the thermoregulatory set point in the anterior hypothalamus, which basically then causes your body temperature to increase. There's no effort in that the animals will show to remain normothermic, meaning that there's no panting, no seeking of cool places, for example. Often you will actually see the opposite. You might see some piloerection and also shivering for the body to try to maintain the higher set point. Hyperthermia, on the other hand, is a lack of change to this temperature set point, and basically is external and internal factors that causes an increase in the temperature, and the animal is typically showing efforts to remain normothermic. So you'd expect to see that the patient might be panting or again looking for cool places. So the typical causes of hyperthermia, like I said, it's typically associated with internal or external factors such as overheating and from, for example, an increase in external temperature. And you can see temperatures higher than 41.1 degrees Celsius, which is uncommon in patients with fever. Hyperthermia in the figures is more like this. You have, for example, environmental temperature or, for example, seizures causing an increase in body temperature without a change in the temperature set point. So the causes can also be divided into environmental and medical causes for hypothermia. The environmental causes are typically associated with, for example, high temperature outside, and the animal is, for example, running after a ball with a outside temperature of 29-30 degrees. They might become overheated quite quickly. You can have exercise or activity associated with the increase in temperature as well. Remembering that healthy exercising dogs, their temperature can increase to 42 degrees actually. And you also have stress, which we've all seen in the hospital or in the clinic, where some patients or ours will have an increase in temperature because they're really quite stressed. You have medical causes as well. That is really, or it is important to remember. If the animal does not have any history of being outside running or exercising, for example, which could be hypermetabolic or metabolic conditions such as hyperthyroidism or hypocalcemia. Hypocalcemia typically causing an increase in muscle fasciculations or even seizures, which then again can cause an increase in temperature. Same with opioids and ketamine in cats, can cause them to be excited or developing excitation, more likely. Also muscle tremors, that same can be seen in serotonin reuptake inhibitors as well in both dogs and cats. You can have intoxications that can cause this, such as cocaine. Cocaine is highly toxic for our dogs and cats. You have malignant hyperthermia as well, which is a rare life-threatening inherited disorder that can cause disease of the skeletal muscles, causing an again increase in temperature from the normal muscle function. You have naturally seizures as well, again causing that excessive temperature production in the muscles. Then you have fever. So like we just said, fever is an increase in body temperature due to change in the thermostasis caused by pyrogens, and is a part of the non-specific adaptive body response to a disease process, and rarely exceeds 41.1 degrees Celsius. So in the figure, it would look like this, where you have the old set point, or you have normal temperature, where the brain will be affected by cytokines or other pyrogens, where they would trigger an increase in the internal set point, where you get a new set point causing a fever. So the pyrogens that we typically talk about are either endogenous or exogenous. The endogenous pyrogens are typically cytokines, and IL-1, IL-6 and TNF-alpha all will work on the brain, causing an increase in the temperature set point. IL-1, IL-6 and TNF-alpha are all produced by neutrophils and monocytes, which are important in both inflammatory and infectious diseases, and potentially also produced by either primarily from a tumor, or it could also be a secondary inflammatory response to, for example, a neoplastic process. Typically what these causes, these increases in the cytokines, will then cause a neuronal change, and you will have a development of a fever. Exogenous pyrogens can, for example, include lipopolysaccharides, which are a component of, for example, gram-negative cell wall. Antipyrogens, on the other hand, will also be produced at the same time and include glucocorticoids, neuropeptides, and also anti-inflammatory cytokines such as IL-10. These contribute to such degree that your fever truly will increase more than 41.1 if it is truly a fever. So what about the risks and the benefit of developing a fever? So actually, developing fever can be beneficial, and it's been shown in critically ill people that you're more likely to survive, and also you will have a shorter stay in hospital if you do develop fever as a response to, for example, infectious disease. This has also been shown in rabbits, where rabbits infected with Pasteurella multocida were more likely to survive if they developed a fever. We also know that these two benefits of fever are probably because of improved function of the immune system. So we can, with up to an increase of 41.1 degrees Celsius, neutrophil mobility and phagocytic abilities increases. We also know that macrophage and lymphocyte proliferation improves. So the fact that your immune system actually works better up to 41.1 degrees makes you more likely then to get rid of, for example, bacterial infection. Fever, or the production of cytokines, so the pyrogens that induce the fever, also can induce production of heat shock and acute phase proteins, which are important free radical collectors, and actually they can preserve cellular components, which then can actually help save some of the tissues in the inflammatory state as well. And I think it's important to note that fever does not kill bacteria, because most of the bacteria are actually they can grow fine in temperatures up to 41.1 degrees. But the fact that you have an improved immune system makes the immune system more likely to kill the bacteria. Then the costs of fever are a few as well, where you have increased number and severity of clinical signs, especially I'd say having man flu. You know that you're going to feel rubbish, and your severity is a lot worse than in women. So being sick from man flu definitely makes you feel you have a reduction in welfare. But the good thing, and which we always will hear, is that there's unlikely to be harmful to you. But the animal, or as people, can definitely feel more rubbish when we have fever. There's also an increase in metabolic rate, up to 1.3 times normal rate, which then can be associated with development of energy deficits, increase in oxygen demand, and also CO2 production. And then with increase in temperature, you get a right shift of your oxygen saturation curve, which then could potentially cause a change in oxygen delivery to the tissues as well. So then I just want to kind of go through the way that we measure temperature, because most of the time we do end up using rectal temperature, and the reason why we do use rectal temperature, it is very closely related to the core temperature in dogs. So when we measure rectal temperature, we think that it reflects the core temperature, or at least very close to the core temperature. This study has not been done in cats, but we do think it is very much the same. There are other studies out there that have shown that we can both use auricular or tympanic membrane or axillary temperatures, and I would tend to use these more as a monitoring in, for example, hospital, and especially in for example, in dogs with a lot of diarrhea, where they're very sore in the perineal area and they will refuse rectal temperatures. Then I would consider to use auricular or tympanic membrane temperatures. And the reason why I would use that over axillary, because it was shown in a paper from 2013, was that was related better to rectal temperature, with less measurements more than half a degree away from the rectal temperature, and therefore also probably the core temperature. Whilst in cats, I would be more happy using axillary, again, because of very similar reasons. And it was a study again from kind of the same group that showed in 2015 that was better in cats. Just putting in the normal temperature as well, and also just important to remember that dogs can increase up to 42.2 degrees after exercise. So if you have a seizure, or if you're not sure whether this is fever or hyperthermia, it is important to try to monitor the temperature over time. And again, in cats, it's been shown that they can increase up to 39.7 in consult. Then we're kind of moving into the areas of fever or pyrexia of unknown origin. And please excuse me that I'm probably going to say PUO or FUO a little bit concurrently. I'm used to using PUO in the clinics, but I will try to stick with fever of unknown origin. But please, if I do say FUO or PUO, that basically means the same. So how do we define fever of unknown origin? So this is a modified definition from human medicine, which we technically should use for kind of true fever and unknown origin, is a persistent fever more than 39.2 degrees on several occasions, and that should have been going on for more than 3 weeks, or the diagnosis has not been found after 3 or more visits or 3 days of hospitalization with appropriate investigations. And typically when we talk about appropriate investigation is to do a thorough history and physical exam by hematology, biochemistry, urinalysis, and no kind of reason for the fever has been found just based on those investigations. Unfortunately, it's very rare that we have true fever of unknown origin patients. So a looser term about fever of unknown origin is, or at least what's more commonly seen, is that the referrals that one gets for fever of unknown origin is typically a patient where the fever is persistent despite antibiotics for 7 to 10 days, which isn't necessarily a bad way of thinking about it. And some of the kind of the reasons or the causes of fever that we're going to go through later probably would not necessarily fit into the FUO category, but it's important to think about when you're working up a patient with fever. FUO in people. So in people, they've found that more than 200 diseases has been associated with FUO. So by actually having a fever for more than 3 weeks, or not found an underlying cause with 3 more visits or 3 days of hospitalization. And in people, they're divided into infections, tumors, non-infectious inflammatory diseases, and miscellaneous. It's a little bit different in veterinary medicine. So the causes that we see in veterinary medicine, and the way that most papers and also most chapters would divide these causes into, would be infectious, inflammatory, immune-mediated, neoplastic, and miscellaneous. So in front of you, you see a slightly busy slide, but I just wanted to kind of show you the references that we're going to use going forward in this talk. So I've used a lot of the bases for this talk is based on a chapter by Ian Ramsey and Sivert Tasker, which is basically from Ettinger, the internal medicine book. But also there are 5 studies where there's been more of a large group of dogs looked into and then figured out what the underlying reason for their fever were. So we're going to go through these in more detail, and we're going to base what we find as most common causes for fever in dogs and cats based on these studies. So as you can see, 4 of them are in dogs and only 1 of them is in cats. So we're going to, unfortunately, we don't necessarily have the same amount of evidence or in detail in cats compared to dogs, so that will be a little bit different. But hopefully what I'm aiming to do is to show you kind of what are the most commonly diagnosed underlying causes for pyrexia or pyrexia of unknown origin based on these papers. So we are then going to go through kind of the causes first. So we're going to start with infectious causes, continue with inflammatory, then immune-mediated, neoplastic and miscellaneous causes for fever. So we're going to start with infectious. Then we're going to start with the infectious diseases, which is commonly associated with development of fever. When we go through the next couple of slides, you're going to see in parentheses, you're going to see a C and a D, and the C is for cats and the D is for dogs. And it's just trying to highlight what is more likely, which of the species are more likely affected by this disease or infection of this organ, for example. So we're going to start with bacterial infections. So both systemic bacterial infections, but also local, are associated with fever or development of fever. And I think it's really important to consider, so what I kind of want you guys to just have in the back of your minds is that when we go through all of these things, are there anything in particular that you want to ask an owner coming in with a dog or a cat with a fever? You know, there's certain questions that we need or want to have asked before we progress with our investigations, because that's going to help us a lot in the workup. So the systemic infections, so any type of bacteremia can cause a fever, and also whether we call mycobacteria systemic infection or not, I think we can, some authors probably will discuss that, but mycobacterial infections, some of them are very widespread, so I put them into systemic. However, the local ones are stuff that you guys will see regularly in practice, such as skin subcutaneous, for example, cat bite abscess. You will have dental disease, and actually it's fairly rare that you have true fever of unknown origin because of dental disease, but it can happen, and it is important to just keep in the back of your mind as well. You have pulmonary, pleural, abdominal, liver, kidney, prostate, uterine, bone, spine, joints, and cardiac. So basically every organ can be affected by a bacterial infection, and therefore there are certain key questions in history or on your physical exam which will help you decide whether you think this is a bacterial infection. For example, if you have one joint affected, which is really swollen, really painful, versus multiple joints affected, which one would you think is more likely to have a bacterial infection? Probably the one with the one painful joint. Then moving on to viral, fungal, protozoal and vector-borne diseases. Starting with viral, these are typically the infections that you associate with vaccinations, so which is really important to consider if you have an unvaccinated patient or a recently vaccinated patient. So asking that question whether the animal is vaccinated or not is really important. The same thing in cats, where you have feline calicivirus or herpes virus can cause upper respiratory signs and potentially fever. FIP is very commonly associated with a fever, and also perhaps is one of the most common causes for PO in especially young cats. FIV, FLV is really easy to forget about, and all patients or all cats presenting with a fever probably should have their FIV, FLV test done. Pox has been shown to is present in the UK, and the same with parvovirus, and also something to consider, especially pox, if you have some cutaneous changes or pulmonary changes. Then you have your fungal infections. Aspergillosis is definitely something that we do see in the UK. Probably the rest of them more likely to be found in the US. However, some of them can also be associated with, for example, traveling. So histoplasmosis is endemic, or has been reported to be endemic in certain areas of Europe, such as Italy and Germany and Turkey, and can definitely cause a fever, especially if it's disseminated. Aspergillosis, moving back to that, it comes most commonly is seen in dogs and cats as sinonasal aspergillosis. In dogs, it doesn't necessarily cause a fever that often. If the aspergillosis is systemic, it can cause an increase in temperature in dogs. It's commonly associated with German Shepherds. So having a German Shepherd that is systemically ill, that is not responding to antibiotics, that should be a consideration. In cats, it's more common to see a sinonasal, or even more commonly a sino-orbital asper, so which can look a little bit like a mass. So if you have a cat presenting with either ocular or nasal disease that should, potentially with fever, should be on the list of differentials. Blastomycosis, coccidiomycosis, sporotrichosis, and pythium, again more common in the US. So if the patient has been to the US, in the Gulf area, or in Ohio or Tennessee, it should definitely be a consideration. Ohio River Valley, I should say, should be a consideration for fungal diseases. That, again, therefore, the question about whether the animal has travelled is really quite important. Protozoal infections, Babesia, again, more commonly in Central Europe, but we have had spontaneous infections, or sporadic, infections in Essex, without the patients having any travel history. So that's an important differential in your anemic and thrombocytopenic patients. Hepatozoon is present in Mediterranean Europe and Balkan areas, and again, with the travel history, it could be a consideration in an anemic patient. Toxo, definitely present in the UK and can cause systemic disease in both dogs and cats, but it's quite rare. Leash, also very common in patients being, for example, imported from the Mediterranean areas or from South America, for example. It's not present in the UK, but the vector has been found in northern France, so it could be moving closer and closer to the UK. We also have recent evidence that leash can also transmit between dogs living in the same household. The vector-borne diseases, mainly Anaplasma, Borrelia, Lepto, and potentially Nocardium actinomyces being a consideration in the UK. You do have the occasional Ehrlichia seen in, again, travelling patients, and tularemia is more common in northern part of Europe. Hemoplasma, again, not very common in the Europe. In dogs, but is definitely seen in cats. where again it can cause a disease similar to IMHA, so it's an important differential in those cases. You also have Yersinia pestis, a plague, again more common in Asia, Africa, and Americas, associated with, for example, flea bite, and Bartonella, probably most associated with endocarditis. We don't have a lot of evidence that it does a lot anything else at the moment, but there is a lot of investigations into what Bartonella potentially can do. Then when it comes to the most common infectious causes, again, when I'm grouping these guys into the most common infectious causes, this is based on the papers that we looked at, or that we talked about before. So it's based on basically the number of cases that were reported in those papers. So in dogs, what was most commonly reported is that infectious diseases is most common in young to middle-aged dogs. So the average or the median was 3.6 years of age. In the Blackett and colleagues paper from JSAP 2019, basically looking at young animals presenting to the hospital with fever of unknown origin or with pyrexia, and they found that dogs diagnosed with infectious disease was younger than, for example, inflammatory immune mediated. So that was 6 months of the infectious causes versus 10 months in the inflammatory immune mediated. The most common causes reported was bronchopneumonia, soft tissue abscesses, osteomyelitis, discus spondylitis, endocarditis, toxo, and pyelonephritis in dogs. In cats, also similar finding, where you have younger animals being affected. You have 2 years of median age. Most common causes was FIP, which was leading, definitely the leading cause. You have cellulitis abscesses, pyothorax, UTI, pyelonephritis, mycoplasma felis, infection in the lower airways, and also neutrophilic cholangiohepatitis. So of all of these causes, it's important to remember again that this is a paper from a referral hospital, which then potentially can skew the picture over to FIP more than, for example, cat bite abscess. However, it is really important to consider FIP in a young cat presenting with fever. Then going on to inflammatory immune-mediated diseases, I kind of group them together just because it can be a little bit, there's definite overlap here. I'll try to explain why I've kind of grouped them as I have. And please don't hesitate to be in contact if you disagree or if you find that it's a bit confusing. Then of the inflammatory diseases that we have, commonly reported as steatitis or fat necrosis, which is more commonly seen in cats than in dogs. Hypereosinophilic syndrome, again, more commonly seen in cats than in dogs. I would argue that juvenile cellulitis and myositis, either masticatory muscle myositis or polymyositis, both have evidence that it's more likely to be associated with immune-mediated disease and should therefore kind of be boxed in immune-mediated disease, which I will do on a later time. But kind of reported in these papers, these diseases were put into the inflammatory box. The other disease that is probably more appropriately put into inflammatory causes is pancreatitis or sterile pancreatic abscesses. When it comes to the immune-mediated diseases, there is quite a few, but immune-mediated hemolytic anemia definitely can cause fever, more commonly seen in dogs than in cats. We have immune-mediated polyarthritis and polymyositis, immune-mediated thrombocytopenia, all of which are more commonly seen in dogs than in cats. Polysystemic immune-mediated diseases such as SLE can also be seen. SRMA or steroid-responsive meningitis arteritis, also very common, probably the most or amongst the most common causes for PUO or FUO in young dogs. vasculitis, nodular panniculitis, and trapped neutrophil syndrome. Trapped neutrophil syndrome is quite rare, but definitely can be seen and also can cause an increase in temperature. Then, again, using these papers to kind of group and find the most common inflammatory causes, then again, I have put a question mark behind dogs, just because most of the causes reported would now be considered immune-mediated, except for potential pancreatitis, which then we could potentially put in under here. However, in cats, the most common causes or of the ones grouped into inflammatory causes from the study by Sarah Spencer, pancreatitis, sterile peritonitis, lymphadenitis, panniculitis, lower airway disease, for example, feline asthma, lymphocytic cholangiohepatitis, and CNS disease were all seen in those cats. They're a little bit older than the infectious or infected cats, if you can call it that. So the median age in these cats were about 5 years of age versus 2 in the infectious group. Then moving on to the most common immune-mediated causes, and in dogs, the median age was 3.8, so kind of in adult dogs. There's a question mark whether females are more likely overrepresented, and that depends a little bit on the paper that you look at. In people, so in human beings, females are more likely to develop autoimmune disease. And bearing in mind that quite a few of the studies are published out of countries where spaying is very common, maybe that plays a role in the canine population. However, in some papers, for example, in neutrophilic lymphadenitis, females were overrepresented, so it might be that it is true in the canine population as well. The most common causes, the reason why I've put 2 of them in red is because these 2 are by far the most common causes of or immune-mediated causes of PUO, and potentially also the most common causes for PUO as a whole, or FUO, sorry, as a whole. Immune-mediated polyarthritis and CNS inflammatory disease, especially SRMA, very common, and especially in the black study, again looking at young dogs, found that these 2 were the most common immune-mediated diseases. Beagle with Border Collie and Springer Spaniel coming up as the most common breeds. You can also sometimes see certain dermatopathies, such as panniculitis, as typically sterile panniculitis, and juvenile cellulitis. You have masticatory muscle myositis, immune-mediated thrombocytopenia, and lymphadenitis coming up as potential causes as well. And again, this is based on the studies that these were, by numbers, the most common causes. In cats, we see a little bit of an increase in age, so they're kind of middle-aged to older, with a median of 8 years of age. And again, most common causes are IMHA and IMPA in cats. Then moving on to neoplastic causes, and again, I think it's important to consider whether there are any key questions that could, in the history, that can help you decide whether you think it's more likely that the presenting animal with an increase in temperature has a neoplastic cause. So, of the most common causes that can cause an increase in temperature, lymphoproliferative diseases such as leukemia, lymphoma, and multiple myeloma, probably the most common, but any type of necrotic and infected tumor can cause an increase in temperature. Based on the studies that previously discussed, there were actually adult dogs of 4.6 years of age, so they're older than the other groups. Most common causes were leukemia, vertebral neoplasia, such as multiple myeloma, and actually hypertrophic osteopathy, which is a reaction of bones, secondary, but not exclusively to pulmonary neoplasia. In cats, again, middle aged to older, and most common causes were lymphoma, pulmonary carcinoma, leukemia, and GI adenocarcinoma. And among of these, lymphoma probably the most common, also just because it's a very, very common disease or neoplastic cause that we can see in cats. Of the miscellaneous causes, drug reactions from, for example, sulfonamides, which can cause multiple type of reactions. For example, polyarthritis can definitely cause an increase in temperature. You can have vaccine reactions causing a fever, certain hormonal remedies, and serotonin reuptake inhibitors as well can cause a persistent fever. Myelodysplasia, which is a pre-cancerous bone marrow disease, can also cause it. Panocytitis, the acute inflammation of bones and growing typically large breed dogs, can be an important differential for a young dog presenting with multi-leg lameness, and also is important to consider if you don't find any changes to the joints but actually pain in the long bones, then panocytitis should be on the list. Polysystemic shunt and IBD might predispose animals for developing bacteremia, and was reported as a miscellaneous causes of some of the older papers. In the study from Sarah Spencer, then cats were grouped into miscellaneous if they had intestinal obstruction, urethral lithosis, intussusception, perivenous pseudocyst, trauma, and hippocampal necrosis, all causing an increase in temperature. Now then, having talked about the different causes of it, now we're going to talk a little bit about the approach to the pyrexic patient. So I think the key, which you kind of touched on a couple of times already, is to figure out whether this is fever or hyperthermia. Hypothermia might need urgent care. For example, if you have a dog being out on Hampstead Heath a few weeks ago, we had very, very warm temperatures running around after a bull, and if that dog then basically becomes overheated, or they can develop heat stroke, they definitely need quite urgent care, more typically urgent than necessarily a feverish patient. So again, trying to figure out what could have happened. Could the animal have had a heat stroke or seizures, or could the cat be hyperthyroid? Most of the time you will see the patient as it comes in, it will show signs of trying to cool itself. So, having been thrown a ball out on Hampstead Heath, that patient would typically be panting, trying to stay cool, might be a little bit flushed, so might have some hyperemic mucous membranes, and really wants to lie down. Whilst fever, as we said before, it rarely increases more than 41.1 degrees Celsius. The animals tend to feel ill. They tend to be depressed, anorexic. They can be have an increase in breathing, or they can actually seem a little bit stiff, as you know from having fever yourself. You can feel, have an ache everywhere. But most of the patients with the fever, unless they have sepsis or bacteremia, they wouldn't necessarily need urgent care compared to hyperthermic patients. The other thing is, when you can establish, okay, this is fever, it's really important to use the history effectively. So it's really important to try to get as much information as you can from the owner, because a lot of these cases will have very mild or very vague clinical signs, which then can make your job a lot more difficult for you, and therefore it's important to try to really question them, and also kind of to try to remember certain kind of key questions like we talked about before. Has the animal ever travelled? Is the animal vaccinated? For example, is it a hunting cat, or is it an indoor cat only? Also, I think it's really important that you do take time to do your physical examination properly. So, Are there any things that we can think about when it comes to kind of the history and physical exam that we need to think about when it comes to infectious diseases? So what about signalement? Well, we do know, based on the study from Black et al., the average age for infectious causes was 6 months versus 10 months for inflammatory immune mediated. We also knew from the other papers that younger animals were more likely to have infectious inflammatory versus other diseases. We also know that a certain, is it a hunting cat, then that cat might be more likely to develop toxoplasma or potentially pox virus, or has been in contact with other dogs and cats, or is it from a multi-animal household? Or any of the other animals that this patient has been in contact with, are they ill? Again, travel history. We know that there are more infectious diseases around the Mediterranean compared to in the UK. Have the owners seen any ticks or fleas? Helping to consider whether you think a vector-borne disease is very likely. Vaccination status, as we talked about, any previous medical history, for example, dental extractions. Did something go wrong on the previous dental extraction? Might they have some residual infection that hasn't gone away? Any recent surgery, for example, could have been a gauze left behind? Is there a surgical wound infection associated with that? Multi-cat household, fighter, hunter, indoor, outdoor. The other thing is also to consider urinary signs and also their diet, knowing that, for example, raw fed animals might be more likely to develop infectious causes. So on your physical examination, it's really important that you do a thorough palpation of the body, feel, use your hands, feel everywhere, check every toe, check every nail, do a thorough oral exam as well. Is the dog a stick eater? Could have had a wound to the back of the throat, for example. Are there any ocular nasal discharge that you can see that the owner hasn't really thought about? And also, are there any ocular changes? For example, could it be if there's a young cat with uveitis and, for example, ascites, that would make you very suspicious of FIP. Check the lymph nodes, and I think this is very easy to forget when you do your physical examination, but definitely can give you a hint. For example, if one lymph node is enlarged, do we think that, okay, then make sure that that area which drains to that lymph node is really thoroughly examined. Maybe that's where you find your wound or your infected toe or similar. Do a rectal examination as well, to make sure that there's not anything happening in the anal glands or in the prostate if it's a male dog. Do a fundus examination if you're comfortable with it, but again, because changes to the eye might reflect a more systemic disease. Then, things to consider when it comes to inflammatory diseases or immune-mediated diseases. I think we haven't talked about breeds that much in this group, but I think what is really important to consider is that when it comes to these inflammatory diseases, we know that, for example, SRMA and the breeds predisposed to SRMA, such as young beagles, will make you a lot more confident that this might be an inflammatory or autoimmune disease, such as if you have a young beagle coming in with neck pain, you're a lot more likely to think that that dog might have SRMA. Certain other breeds as well that is a lot more predisposed to developing immune-mediated diseases, such as Cocker Spaniel and Springer Spaniels as well. Say you have a Springer Spaniel with multiple or all the lymph nodes are really, really enlarged. Maybe then you are more likely to consider that this could be generalized lymphadenitis. The other thing that would make me a lot more suspicious about inflammatory or immune-mediated is whether the patients had any similar signs before. For example, we can quite often see that for SRMA can wax and wane, and they can feel great one day, then the following morning they're really stiff in the neck, they feel really rubbish, they don't want to eat, and then within 24 to 48 hours, again, they're almost back to normal. So, and having had a couple of episodes of those kind of vaccine vening episodes at high temperature will make me a lot more suspicious of SRMA. Has the activity or ability to jump into the car on the sofa or lift his neck has changed? Again, IMPA or SRMA. And again, why I'm kind of harping on about these two diseases is because they are the most common diseases seen causing fever of the inflammatory immune-mediated disease group, and probably altogether the most common cause of PUO. Again, anorexia and ability to open mouth. Actually, check with the owners. Sometimes they forget to tell you that, but that the way that they're eating has all of a sudden changed. And again, the diet could also be helpful, and more in the sense that we can, if the dog was fed a really fatty meal before developing a fever, then maybe you're more likely to consider pancreatitis as a cause. Again, do your full physical exam. I know how difficult it is to do all of this in 10-15 minutes, which is basically your consultation time, but actually taking the time to do it thoroughly might help both diagnose the cause a lot more easily, but also you will feel a lot more comfortable kind of continuing with more advanced diagnostics if you know that your physical examination did not reveal any changes. So again, do your oral exam, make sure that you can open the mouth, palpate and manipulate the head, neck and spine, check the joints, are they fused, are they painful in the manipulation, are they painful in the abdomen as well, potentially, if you think it's related to pancreatitis. Then when it comes to neoplastic causes, perhaps, or some of the things that make me a little bit more worried about neoplastic causes naturally is if it's an old patient, but also if they have had weight loss, and especially if their appetite has been fairly the same, but they continue to lose weight. The other thing that might make me a little bit worried also is PUPD, as we know that there's quite a few of the cancers that can cause, for example, hypercalcemia with the secondary PUPD. Lymphoma, T-cell lymphoma can cause this, and weight loss, PUPD, maybe they're coughing a little bit if they have intrathoracic disease. They might have some lumps and bumps around the body. Just make sure that they've been checked out, and all of these things will make me a lot more potentially thinking about, could the cause of this fever more be neoplastic than any of the other causes. Again, for full physical examination, make a body map, make sure that you know which one has been sampled. Do check the peripheral lymph nodes. I can't stress this enough. I know how easy it is to forget, and also but try to remember it. If you have a feverish patient, get your colleague to have a feel as well, because sometimes it can be really tricky to find the lymph nodes, or if you're just not certain whether the submandibular lymph nodes could be salivary glands or not, get someone else to have a feel as well. Do your oral and auricular exam, especially focus on the tonsils. Don't forget the tonsils, because the squamous cell carcinoma can be hiding in there. Palpate the testicles and do a proper rectal examination, again, especially if it's a male dog. So the way I like to think about it when I do my physical examination is that I move from head to tail. I don't really mind how you like to do it, but just as long as you have, make sure that you've basically have checked all the parts of the body in the animal, so that you can feel comfortable going on. If you don't find anything at all, you need to do more investigations, and you're comfortable that no, there's absolutely nothing on the physical examination that I could have found before spending a lot more money and doing a lot more. Or also, if you do find something on your physical examination, that's going to help your investigation so much, because then you can focus on that not necessarily blindly going in on that, but definitely focus on, for example, if it's joint pain in more than one joint, then maybe you're more suspicious of an immune-mediated polyarthritis versus something else. So do remember to check the head, chest, abdomen, do your rectal, check your toes, check the joints, make sure they palpate the spine, manipulate the tail, all of these things, check the genitals, to absolutely make sure. In most of the true FUO cases, you probably won't find anything at all. And if you don't find anything at all, then what do you do? Well, I think it depends a little bit on how sick the animal is. So if it's a mild, it's a fairly acute onset, the animal is actually doing okay, eating okay, not particularly ill, then I probably would just monitor. I would keep an eye on what's happening, and then if there's no resolution or worsening of clinical signs, do some further investigations or potentially try some different type of treatments. However, if it's chronic or if the animal has quite severe signs, then I would recommend to do kind of more of an aggressive approach, where you start with hematology biochemistry, preferably sent to an external lab, urinalysis, you do retroviral testing in cats, again, really easy to forget. Consider urine culture, especially if they have urinary tract signs. And again, if there's no apparent cause, then some authors would suggest that you do a 5 to 7 day course of an appropriate empirical antibiotic such as amoxicillin or amoxiclav. And again, I would say that if there's no apparent reason, I would recommend referral before antibiotic treatment, because we know that potentially can affect the ability to find a diagnosis. And if you don't find any reason based on kind of your initial testing, then I would probably then do either, like I said, refer on or do further investigations. The reason why I said about antibiotics affecting the ability to get a diagnosis is because it has been shown that certain treatments can, so both in the Spencer study but also in the Black studies, so those are the two most recent studies, they show that in cats antibiotics were given in 82% before referral, and said in 65% of these paroxy cats before referral, and in those cats, actually pre-treatment did not affect the ability to reach a diagnosis, and the same was seen in the Black study from 2019 in the young dogs, where antibiotics and NSAIDs were given to approximately 60% of the patients presenting to them. Again, pre-treatment was not associated with ability to reach a diagnosis, but in the Battersby study, pre-treatment actually influenced diagnosis. So even though the newer papers didn't show that pre-treatment affected outcome or diagnosis, I think I'd still be a little bit hesitant about trying a lot of treatment before referral, but naturally that also depends on the owner's ability to afford a referral or further investigations. Then, kind of when we talk about further investigations, we can divide them into a tier system. Basically considering that first tier, or the first investigation that you do in these patients with the fever, you would do your hematology and biochemistry, your analysis, FIV, FLV, snap test if it's a cat, radiographs of chest and abdomen, and then you aspirate anything that's abnormal on your physical examination. For example, if it's an enlarged lymph nodes, then you might have your diagnosis there. However, if you don't find anything at all, maybe then do a bit more advanced investigations. That might include urine culture, again, depending a little bit on what you think is happening. Basically because some animals might have subclinical bacteriuria, But in these cases, if you do find bacteria in the urine, you might be more concerned that this is actually a true pyelonephritis, and therefore a urine culture might be sensible to do. You might want to do serology or PCR depending on the geographical region or travel. So again, you might do a lot more testing in the patient that has traveled compared to a patient that hasn't. You also might want to do a bit more advanced imaging, such as echocardiography, to make sure that there's no evidence of endocarditis. You want to do an ultrasound or a CT, just to make sure that you've do something, especially that is a lot more sensitive compared to, for example, abdominal radiographs. And in some cases, you even include CT of head, chest, abdominal, spine, basically because you haven't found the reason and you're trying to be as thorough as you can. That being said, again, depending on your finding on your physical examination, I think that's more important. So if you do have a coughing nug, then imaging of the chest will be more important compared to imaging of the head in that patient. Then also, I would consider CSF and arteriocentesis as second tier, just because of, again, how common you will see SRMA and IMPA in a lot of these cases. And if you don't have any evidence whatsoever of an infectious disease on your kind of initial investigations, your serology or PCRs, on your further investigations such as bicavitary imaging, so chest and abdominal, so chest rads and abdominal ultrasound, you don't find anything there, then CSF and arteriocentesis might be the next step. Then third tier would be then kind of your more advanced aspirations or basically flushes based on your findings. So bronchoalveolar lavage, prostatic wash, tracheal wash. Again, depending on what you find on your imaging, for example, lymph nodes, you might sample them even though they're normal in size. You do cultures, you might do blood cultures, fecal cultures, again, or culture of your bronchoalveolar lavage. You might end up doing bone marrow because you're concerned that it might be a cancerous disease or myelodysplastic component here. Tissue cultures, again, based on findings on your imaging. And if you don't find anything at all, or you're really concerned that this might be a brain issue, considering that it's the brain is where the temperature center is. If you have a tumor or a metastatic tumor in that area, you might not see that on your CT, so you might need an MRI to finally diagnose that. Also, it's really important to recognize that it's not necessarily your first year, and then you do the second year, and then you do the third year investigation. This is very much a dynamic process because it really depends on what you find on your investigations. The reason why I kind of like to divide it into these different kind of treatment options is more because of it can be a bit more. It can help you structure your workup, and also it can help you when it comes to choosing what to do first and then what kind of the next sensible step is. Instead of jumping straight for the MRI, you might want to do some more basic stuff. Which then leads us over to our ability to actually get a diagnosis, and we might not find a diagnosis in up to 20% of dogs and 15% of cats, and the reason for that is either it could be that it might be an unusual disease that we just are not able to diagnose, or in quite a few of these patients actually they will just spontaneously improve, or they have a response to the treatment that is given without necessarily a diagnosis present. So that would mean that about 70 to 80% of the dogs naturally gets a diagnosis and have quite a higher likelihood to survival to discharge. And similar thing is found in cats, then about 85% will have a diagnosis. When we can't find it in 15%, then the rest probably will have a diagnosis, and 67% of these will survive to discharge. I think the difference in kind of diagnosis and outcome in cats is both related to this has just been taken from the Sarah Spencer study, but also the fact that it's quite a high prevalence of FIP in that study, which will naturally affect outcome. The pictures of 2 PO patients. The cat on the right is called Tinkerbell and is really quite a funny cat with IMPA. She's quite sassy and not that easy to handle, but she's a very, very cool patient. And then on the left, it's Penny, and we're going to go through Penny as a case. So Penny is a 1 year, 2-month-old female neutered crossbreed dog that presented to us with a 3-week history of variable appetite, lethargy, diarrhea, weight loss. And she was also refused to jump into the car, and over the last few days before presentation, the owners thought that they also had heard a cough. There was no change in her drinking, and actually had a travel history to Switzerland about 3 months before presentation. She was up to date on vaccinations and also had several courses of deworming after coming back from Switzerland, and also fairly recently due to a recent development of diarrhea. On physical examination, she had a temperature of 40.1 degrees Celsius, heart rate and respirate were normal, her body condition score is a little bit underconditioned, and she had a moderate loss of muscle. She had a mild abdominal discomfort and also very variable reaction to carpal and tarsal and neck manipulation. So one exam, for example, in the morning, she would be having a reaction in one joint, then in the afternoon didn't have any reaction, and then later on in the evening have a reaction in a different joint. So kind of the investigations that we planned to do were then considered based on her history. So we were then kind of thinking into the groups that we talked about before. So whether it could be infectious, do we think it could be inflammatory, immune-mediated, or neoplastic? Considering that she had a travel history, she had a cough, she had vomiting and diarrhea, and we then wanted to kind of look into infectious diseases that you can find in Switzerland. In Switzerland, they have Ehrlichia, Anaplasma, Borrelia, heartworm, leash, angio, Echinococcus multilocularius is there as well, and Babesia, and potentially Creosoma vulpes, which is the lungworm, potentially could be in Switzerland as well. It's found bordering to Switzerland, so both in France and Germany. What about then our considerations then were, what about whether the travel history might just be, a red herring? It might not have anything to do with the development of disease in Penny at all. So could this be inflammatory or immune mediated? She did have a joint reaction, and however, the vomiting diarrhea potentially can be a little bit tricky to explain why that developed, but at the same time we also knew that the owners had been giving her a lot of different types of diets, trying to get her to eat over this time period as well, so maybe that played a role. Or could it be that the joint reaction was secondary to the vomiting diarrhea? Could she also potentially have a neoplastic cause because of her cough and also the weight loss? That was also considered. So for us to kind of then do some further investigations, we kind of started with, call it tier 1, where we did hematology and biochemistry. We also did urinalysis, which was normal. The heme revealed a mild neutrophilia with mild toxicity, and the biochemistry revealed a mild hyperalbuminemia, suspected to be as a negative acute phase protein from her having fever. We also ended up doing a 4DX, which is a SNAP test or a serological test looking into Anaplasma, Ehrlichia, Borrelia, and also an antigen test for heartworm, all of which were negative. And then we sent off Leishmania in the meantime, waiting for it. Based on this and based on kind of the initial investigations, not telling us what might be happening, we did rule out quite a few of infectious diseases. Then we ended up doing some further investigations. In including bicavitary imaging. So we ended up doing a CT of the chest and abdomen under GA. We also did, before going ahead with the CT and the GA, we did an echo, which didn't reveal any abnormalities to her valves in her heart. We also did blood cultures. And all of this is basically to try to kind of ensure that there were no underlying bacterial infection causing her increase in temperature. The reason why we ended up doing a GA was considering what we discussed before, whether the travel history was just a red herring. We then wanted to do CSF and arteriocentesis at the same time, to try to both be save a little bit of money and not having to sedate her or GA her twice for both the imaging and then the further investigations. We did find actually on the cytology from both Carpi and Tarsa, we found non-degenerative neutrophils and the moderate neutrophilic inflammation consistent with polyarthritis. Then the discussion is, do we culture these joints to be absolutely sure that it's not a septic polyarthritis? Then yes, we should culture. It also depends, I guess, on how suspicious you are of that, and also basically on your cytological findings as well. Because if you have degenerative neutrophils, or your concerns of the clinical pathologists think that they might find bacteria, then definitely that will kind of add to the need to culture these joints. But the vast majority of the polyarthritis are most likely going to be non-infectious. Then we started discussing, okay, we're having a polyarthritis, do we now need to start her on steroids? The concerns that you have in these patients is that Penny was still pyrexic, she was still lethargic, she wasn't really eating, and even though our kind of initial investigations came back negative, it didn't mean that we couldn't, had seen an early endocarditis that didn't have any changes to her valves, although unlikely because it's been going on for 3 weeks. And also we couldn't really exclude that she might not have the bacterial infection elsewhere, which you couldn't pick up on the imaging. So after 48 hours, we got the blood culture back, which was negative, and we called the lab to ask when Leishmania serology would be back, and unfortunately, that would take another few days. So again, you're kind of left with this conundrum whether you want to treat with steroids, which might make an infectious disease worse, or and how likely do you think this infectious disease is? And I think it's important to then kind of look back and go through all the stuff that you've done, the investigations that you've done, and consider how likely is it that without any dermatological changes, without any changes on bicavitary imaging, is it that this is either visceral or then cutaneous leishmania, which we consider a lot less likely. Therefore, ended up treating Penny with steroids before we actually got the Leishmania serology back, and Penny responded really, really well to steroids. Was doing a lot better just within 24 hours, and then was discharged very quickly, and actually even before we got the Leishmania results back, which were negative. For you guys about some useful links when it comes to infectious diseases in dogs and cats, which can be very, very helpful, which would be both from Bayer has a good internet page, ABCD Cats as well, when it comes to infectious disease in cats, and the European Society of Veterinary Parasitology as well does have a very nice internet page where you can look at different type of infections in different countries in Europe, which is very useful if you have a patient that has travelled. The following are the references that I have. If I've forgotten anything or there's any references that you think I've should have included, please let me know. And so thank you for listening, and please do not hesitate to email us at lvs@londonmedspecialists or vet if you have any questions or comments. Thank you so much for listening. Bye.